This isn't a time to sort of market ourselves, but what I actually wanted to do is sort of market what we and many other people are trying to do sort of in the dialysis world today. And that is, frankly, to try and make dialysis access creation and maintenance, bring it into the 21st century. So I'm a vascular surgeon. Chris Durham back there is our chief medical officer. He and Danelle next to him founded our group, and Chris will get up in a little bit. But we are vascular surgeons who are essentially 95% devoted toward AV access only. And I grew up and I spent my life in the academic world. I was at University of Rochester and University of South Florida doing all vascular surgery. And the problem is AV access, which is done by vascular surgeons, transplant surgeons, some general surgeons, a few other people, is very much the poor stepchild and is looked upon as sort of the last priority. Everybody wants to do the transplants and the cool aortas and the carotids and all that kind of stuff. So access gets relegated often to the junior person. It gets done sort of last thing in the day, all that. And I'm not criticizing people because I live this life, but basically when you're at the university or when you're at the big house, and I'm as to blame as anybody, you call and you get a phone tree and you go work your way through the phone tree. You finally get a random appointment with a random person who may or may not be interested 2 or 3 weeks later. That person may need a cardiac clearance. They may need some ultrasound. There's always a cancellation or two. You get booked 2 or 3 weeks down the road in the operating room, and then it's 50-50 if the case gets bumped by an appendicitis or a trauma or something like that. And that's sort of the way it's been ever since dialysis access started to be done. And I was talking to a buddy of mine the other day who runs vascular surgery for the southern half of California in Kaiser, and he said in the Kaiser system, which is managed care, communistic, tell them what to do, it's still 6 weeks between referral and when they get their access placed. So in my career about 5-6 years ago, I began to sort of focus in on AV access, and I joined a guy named John Ross in Orangeburg, South Carolina, who's been doing access for about 30 years. And he was really the founder of the concept of total access care. We sort of say a comprehensive dialysis access center, CDAC. And Danelle visited him and bought in, and Chris visited him and bought in, and I bought in, and through a fortuitous stroke of events, and I'm the lucky one in this group, we all got together. And we are trying to take his original concept and not only do it here, but also sort of identify centers throughout the country and throughout the world that do the same thing. And there's surprisingly few of them. There's us, there's Dialysis Access Institute in Orangeburg, there's 2 other places in South Carolina, and that's because Ross sort of, his tentacles go everywhere. There's a place in Oklahoma, there's a place in West Germany, and it's very rare. There's really less than 10 of these centers around the country. And when I say these centers, what it really is a number, sort of 4 or 5 overlapping concepts. Number one is same-day service or nearly same-day service. And we basically, when you get a referral, you say, come on in today, and you've got enough manpower set up so you can get these people boots on ground. In the ideal world, and it really depends on infrastructure, we can often, as long as the patient comes in NPO, we can get their access done that same day. Now, our center, we don't, but no more than 2 or 3 days. So compared to the 6 weeks it takes in sort of the large hospital system, I would say 2 or 3 days is good. And again, I'm not touting our center, I'm talking about the concept as a whole. We do zone defense, where each one of us does about 90% of the access. There's a few things that only I do and a few things that only Dr. Durham does and a few things like that. But basically, we're a zone defense. Everybody takes care of everyone. You don't have to wait. If your surgeon's out of town, you don't have to wait for him or her to come back. You know, the team will get it taken care of. A lot of that is we all operate in the same way. We have a fairly robust standard operating procedure, which again is sort of going into our consortium plan. So we all know what we've done. We know how to communicate in the op notes, things like that. We control our own operating rooms, which is a big deal. We never have to wait if somebody tries to bump us, if there's an acute appendicitis or a trauma or anything like that. We own the operating rooms. We own our anesthesiologists or our partners, all that. And very important, and I was speaking to somebody a few minutes ago, is longitudinal care. And what I hated many years ago at the university is the surgeons would do the creation, And then down the road, when you needed to do a declot or there were high pressures or things like that, it would go to the interventional radiologists. And for the interventional radiologists, they're good doctors and they're good people, but for them it's just a case. You know, they roll in and the arm is prepped and draped and they know what the problem is and they just take care of it and they go on to the next case. Whereas with us, the longitudinal care is critical. The second go-round of KDOKI really sort of said, you know, make an access plan. And that's all well and good, but you can't follow through and you can't do it unless you're taking care of this person from the time they're first seen for their access till the time that either they get a transplant or they pass away. You've got to control the entire thing. I remember vividly working with a patient who had had 11 or 12 declots over the past year, about one a month, by 10 or 11 different places. And each place would see them and they're clotted and they do a declot. Whereas the CDAC concept means that you'd identify after the second or third declot and you say, there's something going on here. We got to figure out what's going on. So where are we going with this? We believe this by far provides the best possible care. We're actually, as I think somebody said to a smaller group, we're actually writing what is going to be the definitive textbook of dialysis access. There is no textbook of dialysis access. And the nice thing is, I'm an editor. We've got authors from around the world, but this is being written from a CDAC concept. We're dealing with a problem, and we're saying, how do you best take care of this problem, irrespective of whether you're a surgeon or an interventionalist or an interventional nephrologist or anything like that. We're trying to approach this from a multidisciplinary way. And we're also, there's 2 or 3 meetings now around the United States that just deal with AV access provision and maintenance. And we're convening the first meeting of our CDAC consortium. We don't really know what to call it yet, but that'll be in Charleston in June. And again, the goal is to try to advertise and try and create and try to make these places work, try to share standard operating procedures, move things around, stuff like that. So that's what we hope is going to happen. We think we provide good service, but this is a bigger picture talk. This is really sort of saying what people are trying to do in the future. You know, the goal is to do a better job providing access care and make the patients feel more comfortable and everything like that. So that's sort of what I was going to say. We ended there. Any questions at all? Any questions for me? So our group we actually own our own hospital, which is nice. It's a 35, 36 bed hospital, and it's 95% AV access. There's a few other partners of ours who come and operate there, but basically we own all of our own operating rooms, everything like that. And we've got 5 OBLs around the city too that we see all our patients at, and we can do simpler things. So we have transportation. We want to make things easy for the patient. Yes, you know, we'd love to do business, but the bigger goal is to try and sort of improve this thing. Eventually, even training, you know, right now the surgeons train as surgeons, the interventionalists train as interventionalists. It would be nice to train a AV access creation provider. So I think all that's in the future, but for a lot of different reasons, we are definitely leading the way. So.